All right, welcome. Let's take a journey, shall we? But forget everything you think you know about the mind. Tonight we're going deep, deep into a clockwork contraption of sputtering gears, hissing steam, and crackling electricity. It's an absolutely beautiful machine when it's running right, but when it breaks down, oh, the results are, well, they're catastrophic. So, right as we step into the antechamber of this clockwork mind, we're hit with two totally different kinds of malfunctions. First up, you've got delirium. Think of this like a sudden power surge, a temporary short circuit. It comes on fast, awareness flickers on and off, but here's the key. It's usually reversible. Find the faulty wire and you can fix it. But then there's dementia. This is no temporary surge. This is the slow, grinding, relentless decay of the gears themselves. It's gradual, it's progressive, and it is irreversible. And you can see why getting these two confused would be a massive, massive mistake, right?
Okay, let's push deeper. We're heading into the main engine room now, where the lights are flickering. This is where we find the neurocognitive disorders, the places where the core machinery is really starting to seize up.
You know, dementia isn't just one broken gear. It's more like a cascade of failures that brings the whole system crashing down. We're talking memory, problem solving, language, just knowing where you are. All those fundamental gears start to degrade, to splinter, and just shatter. And the most common culprit behind all this decay, that would be Alzheimer's disease. It's like a slow, creeping rust that just consumes the entire machine from the inside out. So, we step in, right? We're the engineers of care. What's our first move? Well, safety is number one, always. Is the environment a hazard? Is this person going to fall? Then we check the other systems. Can they still communicate? How bad is the agitation? But look at that last point, because it is so important. We're not just looking at the machine, we're looking at the whole workshop. That caregiver role strain, that tells you everything about whether this whole setup is going to hold together long term.
Okay, so how do you actually communicate with a failing circuit? You've got to build a supportive environment. I mean, simple stuff. Make sure their glasses and hearing aids are actually there and working. Use clocks, calendars, familiar things to help them orient. But the most important role, the one you absolutely cannot break, is at the bottom. Do not argue with delusions. Seriously, you can't reason a broken gear back into place. It's impossible. What you can do is acknowledge the feeling. I can see you're scared, and then gently, gently pivot. Redirect them to something else.
Now, down in the apothecary, we've got some elixirs that might help. Let's talk about memantine. So how does this stuff work? It's pretty clever, actually. It basically acts like a shield for the brain cells. It blocks this stuff called glutamate from overexciting the cells and letting in a flood of calcium, which is what kills them. It's not a cure, let's be super clear about that. But for someone with moderate to severe Alzheimer's, it can slow down that relentless grinding, buy them a little more time. But you gotta watch out, because the side effects, dizziness, headache, even more confusion, can sometimes feel like you're fighting fire with fire. All right, we're leaving the engine room behind. Now we're entering a hall of warped mirrors. In here, the gears and pistons might be perfectly fine, but the steam pressure, the very personality driving the machine, it's all wrong. It's volatile, unpredictable, distorted. Welcome to the world of personality disorders. So these disorders get sorted into three main foundries. You've got cluster A, that's the odd, eccentric group. Think paranoid, withdrawn. Then there's cluster C, the anxious, fearful types. They're often avoidant or dependent, but where we're focusing our attention is on the most chaotic foundry of all, cluster B. This is the dramatic, emotional, and wildly unpredictable group. This is where things get really intense. This quote, this just nails it. This is the core of what we call splitting, which you see a lot in borderline personality disorder. There's no gray area, no nuance. To them, you are either a hero or a villain. You are the perfect gear that will fix everything, or you are the wrench that's about to shatter the whole engine. It's this all or nothing, black and white thinking. And it's a defense against a world that feels incredibly scary and chaotic to them. And here's the blueprint. This shows you what that instability actually looks like in practice. There's this deep, terrifying fear of being abandoned. There's that wild swing from idealizing you to hating you. That's the splitting in action. And then there's the impulsivity. And so often, this all comes from a place of really severe trauma. So what do? What's our job as the engineer? It's all about the nursing priorities. Be consistent. Be predictable. That's how you build trust. Set firm, clear boundaries. They need that structure. And above all else, focus on safety, because self-harm and suicide attempts are incredibly common, and safety is always, always number one. Now for a totally different machine from that same cluster B foundry. Antisocial personality disorder. The core problem here isn't instability, it's a complete and total lack of empathy. They look at other people and just see, well, tools, pawns to be manipulated, and they can be so charming, so convincing, but underneath it all, there's no remorse. So your approach as a nurse has to be completely different. Forget appealing to their feelings, they don't have them. Your entire strategy has to be built on rock-solid limits and a relentless focus on safety. Your safety, their safety, everyone's safety. Okay, time to descend deep into the apothecary. This is the lab where we brew the volatile, potent elixirs we need to control the machine's worst malfunctions. This is pharmacology.
But before we start mixing potions, let's get one thing straight, and this is so important. These elixirs, these medications, they do not fix a personality disorder. They can't. The real work, the fundamental rewiring, that happens in therapy, like DBT for borderline personality. Think of the meds as lubricant. They're adjunctive. They cool down the engine, they manage the symptoms like depression or anxiety, which makes it possible for the real work of therapy to actually happen. First step, mood stabilizers. These are the heavy-duty regulators. They're like the gyroscopes we install to stop the machine from shaking itself apart. For those extreme mood swings you see in BPD, yeah, these are absolutely essential. And here is our first big, flashing red warning sign from the apothecary: lithium. This stuff is powerful, no doubt, but it is also incredibly dangerous. Just look at that therapeutic level, 0.6 to 1.2. That is a razor-thin margin for error. Anything over 1.5 and you're in toxic territory. And here's the classic NCLEX trap you have to know. Your body gets sodium and lithium confused. So if a patient's sodium is low, maybe they're dehydrated, on diuretics, whatever, their kidneys are going to hold on to lithium instead. And bam, toxicity. Same thing with NSAIDs like ibuprofen. They mess with kidney clearance. You have to know these interactions. You have to know the signs of toxicity. This is a big one. So what happens when the pressure gets too high and the machine starts spinning out into psychosis or delusions? That's when we reach for the second-generation or atypical antipsychotics. The whole point of these is to calm all that chaos down, but with a lower risk of the really nasty movement side effects you saw with the older drugs. And that brings us to another big apothecary warning, this time for olanzapine, or Zyprexa. It works really well for psychosis and agitation for sure. But here's the NCLEX trap, and it's a huge one: metabolic syndrome. This drug has a massive risk for causing major weight gain, jacking up blood sugar, and skyrocketing cholesterol. So here's the deal. If you give this drug, you are now a metabolic monitor. That's part of the job. You have to track their weight, their blood glucose, their lipids. This is absolutely non-negotiable. Got it? You know, our apothecary is just full of different elixirs. The SSRIs, those are your workhorses, the first thing you grab for depression and anxiety. But you always have to remember that black box warning about increased suicide risk, especially in younger people. Then you've got benzodiazepines. Think of these as the emergency smash glass in case of fire button for a panic attack, but they are for short-term use only. They're addictive, and mixing them with alcohol or opioids can literally stop someone's breathing. It's deadly serious. For the long haul, you want something like buspirone. It's not addictive, but you have to tell your patient, hey, this is going to take 2 to 4 weeks to kick in. It's not a magic pill. Knowing which tool to pull out of the bag and when, that's the art of this. Okay, as we move away from the main engines, we're starting to pick up, well, phantom signals. Other systems are sending out these strange distress calls. This is where we get into anxiety, somatic, and dissociative disorders. Look, anxiety isn't just one thing. It's a spectrum, like a pressure gauge. When it's mild, someone's actually more focused. That's a great time to teach them something. As it creeps up to moderate, their world starts to narrow, they get tunnel vision, and problem solving gets tough. By the time they hit severe, forget it. They can't learn anything. You need to use short, simple, direct commands. And then there's panic. The whole system just blows. They lose touch with reality. At that point, your job is one thing and one thing only: keep them safe and get them to a quiet place. Knowing where they are in this ladder changes everything about what you do next. Sometimes the machine's wires get crossed. With somatic symptom disorder, you have real psychological stress that shows up as real physical symptoms. And let me be clear, they are not faking it. The pain is real to them. Our job is tricky. We have to validate their feeling without feeding into the sickness.
Then you have dissociative disorders. This is the machine's ultimate escape hatch. The trauma is so overwhelming that it just disconnects. It unplugs memory, identity, consciousness. It's a way to survive the unbearable. Here, our job is all about safety and teaching them how to plug back in, using grounding techniques to connect to the here and now.
And so, our journey brings us to the central control room. This is the therapeutic milieu, the whole environment. And we're the ones at the controls. We are the master engineers, and it's our job to run this whole place in a way that helps, not harms. So what's the emergency shutdown procedure? When someone starts to overload, you do not meet their chaos with more chaos. You start the de-escalation protocol. Your voice gets calm and quiet. You ask how you can help. You reduce the noise, the lights. You give them space. You offer them choices instead of commands. It gives them back a sense of control. And you set limits. You do all of this not to win a fight, but to calmly, safely guide that overloaded system back to a stable baseline.
And that really brings us to the final question, doesn't it? The human mind, it isn't really a machine, is it? There were no blueprints. It's organic, messy, impossibly complex. It was never designed to be broken in the first place. And so our job as these engineers of care is maybe the hardest job there is, to take all our science, all our structure, and all our compassion and try to mend the delicate, beautiful, and sometimes terrifyingly broken clockwork of a human mind.